Hey there, welcome back to the show. Today I have a very special guest with us, Dr. Sarah Daccarett, a renowned hormone specialist and anti-aging expert and founder of Inner Balance. Dr. Sarah is on a mission to educate women about the impact of hormone imbalance, especially those between the ages of 21 to 50, who may not know that they're experiencing symptoms related to perimenopause. By raising awareness, Dr. Sarah aims to help women optimize their health so they can live longer, happier lives. She's not just challenging the status quo, she's shattering it with cutting edge insights and groundbreaking hormone treatments. Thank you so much for being here, Dr. Sarah.
Thank you for having me, Claudia. I'm so excited to be here with you.
Yeah, I love having women like you here who go against the grain. I have a lot of questions for you, so
Let's
it's
get
going to be
into
a
it.
good conversation. So, first of all, I always like to ask this when guests come on. What made you get into this? What made you specialize really in women's hormones?
This is a great question. And I started because I needed it. I always say that before I started online Inner Balance, I developed a solution for myself. And in my mid 30s, after I had my only son, I never recovered after pregnancy. My hormones never really came back up. And I am a doctor, so I tried everything that there is available. Once I recognized that it was a hormone problem, which even can take a while to recognize that, I realized there's no solutions for younger women on the market. All of the solutions that we have are for much older women just to stop hot flashes, right? And we also tell women that estrogen's bad, for example, or that we need to be constantly lowering it. So a lot of confusion about hormones, but I needed estrogen to feel better. And so there was, again, it was for myself. I realized that conventional medicine was no help for me. It didn't solve my problems. I learned nothing about it in medical school. And so really had to dive in order to help myself.
Yeah, that's incredible. And you were in your 30s, you said, when you had your son? Wow.
Yes.
And and then what? Did you start testing? Did you just do a lot more research? Like, how did you know that you needed estrogen?
And progesterone and testosterone, it was just a
Yeah.
ton of research and a lot of trial and error and trying things. But really, it came down to progesterone for
Hmm.
me. And I realized in my research and experience, and then once I started treating women more and more, and I'm a pathologist by training, so I understand the pathophysiology of disease of the body. And this is where, when you really dive into what hormones do in the body and how someone once told me that hormones are like the CEO of the body, and this is true. They regulate,
Hmm.
they're like the mastermind of every process in the body. And so, if
Hmm.
you really want to get to the core of disease, autoimmunity, painful periods, I mean, you name it, anxiety, depression, everything, they are regulated by hormones. And our primary hormone is progesterone. And once I caught onto that, this is where you could really start to make a difference. And the problem with progesterone is that it's really hard to get into the body. So it's
Hmm.
a very big molecule. And
Yeah.
this is where the science and innovation we have not made any progress for women in decades when it comes to hormone replacement therapy. And a lot
Mhm.
of it is because we've been telling women that hormones are dangerous for them.
Right.
Their own hormones that they make, their very own God-given hormones or whatever, they're
Mhm.
dangerous to them. And so when there's been no research, we've had no innovation. A lot of the creams that we have and formulations were invented decades ago by men. And there's a huge gender data gap as well. So when you look
Yeah.
at the literature, we are treated kind of like tiny men. We are not just tiny men. We do not just need 1/10 of the dose of testosterone, for example. And this is very
Mhm.
common practice, is to give women testosterone,
Mhm.
which doesn't make any sense to me because we're not men.
Yeah.
And you give women testosterone and it increases insulin resistance. It causes bloating and acne and hair loss and a lot of problems for them.
Mhm.
So progesterone is really our main hormone. And I can keep talking about the formulation if you'd like the inner balance.
Yeah, I mean, we can definitely get into let's just kind of go back a little bit because gosh, we can go off on so many tangents here and we will. But, I want to go back to what you were saying about even young women and not having options. So, in one of your Instagram videos, you were saying that you see a lot of female patients in their 20s who have hormone levels that mimic older women, like in their 80s and 90s. Why do you think that is?
There's a lot of reasons this could be. One, we talk about toxins in the environment. All of the women have a lot of beauty products coming at them that are full of chemicals, for example, phthalates, fragrances, parabens, endocrine disruptors like in them. there could be this, it could be the food, the plastics in the food itself, the low quality protein diets. And then also, I think a big, huge reason that we're missing and we don't talk about enough is actually the use of birth control and use birth control at a very young age that's not for birth control, right? So if you put a 15 or 16-year-old girl on birth control for treat her acne or heavy periods, the benefit does not weigh out the risk, here, because you're not using it in its true senses for birth control. And instead, you're basically, I don't think what women understand is that birth control does the exact opposite of hormones. It stops the production of your own hormone, right? So you no longer make progesterone, estrogen, and testosterone as soon as you start taking birth control. That's why it makes you infertile. That's why it stops ovulation, is because you have no more hormones around. This is what's making women extremely sick, right? So, I think I've heard as much as 50%, but I think it's closer to 90 to 95% of women have anxiety, depression, suicidal thoughts, bloating, weight gain, fatigue, brain fog. Interestingly, all the symptoms of perimenopause, they on birth control, and it's because their hormones are gone. And the doctors will tell them, oh, some women just can't tolerate hormones. It's not that she can't tolerate hormones, it's that she can't tolerate you taking her hormones away from her. And this is what you're doing with birth control. And and a lot of women do not recover, just like they don't recover from pregnancy, right? They're not recovering from the birth control, or it can take many years, or they have too much fighting against them. They have the toxins in the diet that they're fighting, plus they're taking this extremely, toxic thing every day, and it's not liberating them. Birth control is not liberating women, it's making them sicker. And we need a different solution, right? We need to have control over their reproductive health without sacrificing their own health for it.
I agree. I think that, maybe years ago when it initially was invented, it was like, oh, it's liberating in that women have more control over their bodies when they can't get pregnant. But I agree with you. It has done the complete opposite. I mean, they wouldn't need women like us if it was helping them. I mean, I hear time and again from women, they go to their doctor and that is what they give them. That's the only solution, is hormonal birth control. And what's nice is that more and more women are getting educated and they don't want that, but yet they're not really being given an alternative option. And then women in perimenopause, it's the same thing. Even if maybe they stopped hormonal birth control or maybe they never use it, they get to their 40s when they start to have these symptoms, and doctors are saying, here, go on hormonal birth control or take an IUD. And I just want to pull my hair out. And I'm like, you already have low hormones. Why would you stop that even further? And it's just for symptom management, but it's increasing the risk of other diseases, right?
Totally. It's definitely. And not only that, I mean, imagine us making a fake testosterone and giving it to men for birth control, and then only studying that fake testosterone, right? And we make, men have all these diseases because of it. And then we don't have any real studies of real testosterone. It would be absurd. People wouldn't stand for it. But yeah, this is exactly what we've done to women. We have tens of thousands of studies on progestin, which is the fake synthetic hormone found in birth control. And we have virtually absent studies on optimal reference intervals, for example, on progesterone, which is our natural hormone. And women don't understand that even doctors don't even understand that progestin is not progesterone. And so we have this huge amount of increases the risk for endometriosis, PCOS, PCOS, heavy bleeding, painful periods, anxiety, depression, autoimmunity. Women are diagnosed with autoimmunity, anxiety, depression at least 4 times higher than men, right? We are the ones being prescribed antidepressants, stimulants, anti-anxiety meds. And this is the solution that doctors have, is birth control and an antidepressant. And it's it's suppressing women. It's awful. It's making them sicker. It's suppressing them. They're not treating the root cause. And we're also not being it's not being addressed from a research and innovative standpoint either.
Yeah. It's so infuriating. It's like, I know all this, and then when you hear it, when you're talking about it, I'm like, oh, it just reminds me of why I even got into this work. And I mean, I shared with you before we got on here that was part of why I started my business and why I do the podcast, because I had hormone issues. I had health issues when I was young. I started menstruating at a very young age. Nobody knew about endocrine disruptors. Nobody looked at my diet, stress, any trauma that I was experiencing. But I would go to my doctor and same thing. They really didn't know how to help. And then when I was about 17, 18, gave me the magic pill. And I was like, well, stupid, young, and I didn't know any better. My parents didn't know any better. And I was like, oh, well, yeah, let's give it a try. And that was it. Things just went downhill. I mean, my periods got a little better because, like you say, they stopped the production. So, of course, I wasn't bleeding really heavy. I wasn't having major cramps, but everything else just went to shit, for lack of a better term. Thyroid nodules, cystic breast, pituitary adenoma, depression. I mean, it was not good. And at 40, almost 42, I'm still repairing my body from that.
Yes, and this is the problem. Very common. Low progesterone, right? So if you're taking away this progesterone, you're going to get ovarian cysts, pituitary adenomas, depression, anxiety. You're going to get endometriosis and PCOS. The root cause of these syndromes is like low progesterone. And then the problem is the doctors will treat it. You have endometriosis or PCOS or heavy bleeding. The treatment's this birth control, just because, well, if we take away your estrogen, that's what we need. We keep telling women that it's bad. Your hormones are what's causing, you're the problem. Again, it's this messaging of telling women that they're the problem. You need to exercise more. You need to diet. We need to take away your estrogen because it's making you sick. This is all just really telling women at the core that they're the problem. No, women are not failing themselves. Medicine is failing women. We are not treating, we're totally failed them. So no, we need to get, address why their progesterone is low. And if they can't, and women do not need to worry because this is really hard to do. You can remove all these toxins. You can stop the birth control, get your diet like really clean, and you can still not recover and make your progesterone again, but you can replenish it, right? You can take progesterone just like men replenish their testosterone. We'll pour testosterone on young and men so that they feel young. Women also have this opportunity that they can take progesterone, estrogen, and testosterone. They don't need to take all, and we can talk about more about that, but they can restore these hormones and heal.
Yes.
Yeah.
Yeah. I mean, it's amazing. And that's why I wanted to have you here, because there aren't enough providers out there who can really speak to this and who could talk about the difference between the synthetic hormones and the bioidentical hormones. So let's kind of segue into that, because you have a company called Inner Balance and you provide bioidentical hormone replacement therapy to women. So can you talk a little bit about that and the actual product that you use?
Yes, definitely. So the bioidentical piece of it's really important, but also the formulation. We want to allow the body or women to metabolize hormones in the way that they were normally meant to metabolize them as well. And so this is where the key is. So like, right, if you swallow hormones, right, you're trying to replenish and get somebody's hormones up, but if you swallow them, the liver gets to them first. So the liver just chews it up and 80% of it's gone. Like it turns into metabolites that just make you sleepy, actually. Oral progesterone makes women very sleepy, irritable, they get groggy. These are side effects. This is not what progesterone is supposed to do, right? Normal women aren't just sleeping during the day. So, and then estrogen also, when you swallow it, it increases it's very small, but there is a potential increase for risk for stroke just because the liver is clotting factors. And so oral doesn't have the highest bioavailability. It's not the best way to take it. And then there's creams, you can put it on your skin. Estrogen absorbs pretty good this way, but progesterone is a really big molecule. It cannot fit through the skin. And it's been shown that when you put progesterone on the skin, it does not protect the uterus at all. Yeah. So, we're kind of limited here. So you can inject it, but not everybody wants to inject every day either. And you do have to inject quite a bit in order to get it to work as well. You could do it under the tongue. That's another formulation, but again, you end up swallowing most of it, so the liver gets to it. And so the reason why Inner Balance is so helpful and different and special is that it's a vaginal formulation. And the vaginal membrane is really porous, and progesterone absorbs right into the bloodstream. So if you can imagine, the pelvis region is really highly vasculature for women. And the uterus is as well. There's a lot of blood flow. So it goes right into the bloodstream, and you can raise levels up to what you were when you were younger. And also the benefit of this is that the uterus, it's called, just like we have liver first pass metabolism, we have uterine first pass metabolism. So the uterus is able to get what it needs. So the intrauterine levels rise for progesterone, and the uterus metabolizes it and makes metabolites that go to the brain and treat depression, anxiety, regulate menstrual bleeding, right? You can stop heavy bleeding with progesterone. You can stop painful periods. If you have painful periods and heavy bleeding, you need progesterone. If you have
Yeah.
endometriosis, you need progesterone. If you have
Mhm.
PCOS, your LH is really high, you need progesterone to stop and lower that LH. You can start with the diet, but it's not, I mean, this is a progesterone deficiency problem. All of these are problems. So getting these levels up, and that's why Inner Balance, we want to make it easy for women too. So you can sign up online and we follow you very closely and do adjustments.
It's interesting to hear you talk about vaginal application because so much of what I've learned is, I mean, yes, progesterone, a lot of women take it orally, some women will do the cream, and we see all different types of clients and who try different things. Like I've been taking progesterone orally for a long time and it has helped with my sleep. But I have also wondered, well, wait, what if I do apply it vaginally? And so many women will, and we see this, we just saw it with another client who they'll start on hormones like progesterone and they won't feel good at first. And oftentimes they'll freak out about it, for lack of a better term, and they'll stop it completely. And they think, and I think so much of it is because of this nonsense that they've been hearing for years that hormones are bad, hormones are bad. And if I'm not feeling well, it must be the hormones. And it's like, well, wait a minute. First of all, you need patience, right? So can you speak to a little bit in regards to why some women don't feel good, if they just start HRT, and like what is the process? How long should a woman wait or be patient for?
There's a 3-month adjustment period. If you're going from really low hormones to like trying to raise them, there is an adjustment, but the body does need to adjust. But that being said, a lot of women do have problems on oral progesterone. So, like, if they don't feel well, it could be the wrong formulation, right? So, it's just oral progesterone that's making them irritable or bloated or, like, having these problems as well. Um, Progesterone and then XO1, it could be the wrong formulation. Some women are started on testosterone only. If you
Yes.
take testosterone only, it's been shown to disrupt the vaginal microbiome, right? So
Mhm.
lactobacillus, acidophilus in the we don't want any diversity in the vagina. We want like one kind of bacteria there, or one or two like similar strains that keep the vagina acidic, and you do testosterone and it completely disrupts this microbiome and increases risk for bacterial vaginosis and yeast infections and other problems as well. So if they're not feeling well, it could be just that they were put on only testosterone and they need the other hormones. It could be that their estrogen, like for women, not only are the amounts important, but the ratios, right? Progesterone is measured in nanograms per milliliter on labs. It is magnitudes higher, magnitudes
Mhm.
higher.
Yeah.
I mean, when you see that 10 on the lab report, that's actually 10,000 picograms
Mhm.
per milliliter. Progesterone gets up to 300,000 during pregnancy. It is like our hormone. We need it literally to like for everything. And
Yeah.
so it could just be that their testosterone's higher than their progesterone or estrogen, like the ratios are not right, so they're not feeling well, and this needs to be addressed. Or it could just be simply this 3-month period where they need to adjust. That's certainly the case with our formulation. Generally, the ratios are correct. Our product is formulated so that the ratios end up, progesterone converts to testosterone in
Mhm.
women. So you don't even really need to give her any testosterone. Just let her body make what she needs, and she'll make the right amount of testosterone that she needs without the acne, hair loss, bloating, weight gain, all the stuff that she doesn't want. So
Mhm.
you can make adjustments as well. But the idea is that with our product, there's a 3-month adjustment. Sometimes with you get some side effects like breast pain or bleeding or irregular bleeding, spotting, and these we wait, they resolve on their own.
Yeah, patience is key. That's what I tell women. I'm like, please don't give up. The
Well, I'm like,
hormones, they really do help. I mean, for me, I know they were life changing.
look, you've been like this for years. You're not going to reverse everything in 2 weeks. Like it's going to take sometimes months. Like this is a natural therapy. You're giving your body the foundation that it needs to heal. Is what way to think about it. And
Mhm.
so this is the light in a sense that you're giving it what it needs to in order to prevent aging and deterioration. And this just takes time for the body to heal. So like a year from now, you're gonna be practically a different person, new woman because you've given your body, your skin, your hair, everything turns over. It's not going to do it in 3 to 4 weeks.
No, unfortunately, I wish it was that easy, but nothing in life is. Nothing in life is.
Anything worth doing.
Yeah, I agree. Your website has some really great videos. So, ladies, if you're listening to this, make sure you go to her website. I'll put all that stuff in the show notes. But in one of the videos, you mentioned that testing isn't always reliable. And I agree with you 100%. Yet so many women want to test their hormones. So, what are your thoughts on that? And can you speak to it a bit?
Yeah, I did training in clinical pathology, which is laboratory medicine as well. And this is a huge problem. One, we do not standardize anything in the US like they do in the UK and Canada. We have, as I mentioned, so part of the problem is the reference interval problem. So laboratories do not actually establish these reference intervals the way that people think they do. So if you look at estrogen, this is really important that women understand this. Estrogen has an upper limit of 400 picograms per milliliter on the lab report. This reference interval was established with 49 women only, 49 women and 100 men. So we actually used 100 men to establish our own reference interval, which should be infuriating to anybody that's listening. And so no manufacturers don't question it or change it, and the labs don't change it. They just adopt what the manufacturer reports, like the big companies that make the instruments. So they don't change it. When you look at progesterone, this has actually not been established. There is no optimal reference range for progesterone, which is our main hormone, and there's no reference interval for it. There are 5 papers, 5 in the entire world, and none of them were written in the US on what should a woman be at? What is her optimal range? Like how do we even know she's low? I mean, this question of this is really understudied, underserved. There's thousands of papers on testosterone, just for reference. I'm sure. You. So when you get your labs back, virtually every woman is told they're normal. And one, it's doctors are not trained. They do not know how to prescribe it. So it's an easy way to kind of get them, unfortunately, get them out of the office, or doctors don't get paid to do it either. So they have to make a living, right? But you need to go to a specialist to get this taken care of. And generally specialists will not, hopefully they don't turn you away, but doctors, they just say oh, everything is, what they end up saying is, what I hear a lot is, oh, all of these are normal, but your testosterone is low. Let's give you some testosterone. And it's because it's the only reference interval that's really been studied and established is testosterone. But estrogen and progesterone are our primary hormones, and they need the same attention, more attention. And so this is why it's unreliable. It's not because, the detection actually that we use is pretty good. So we can detect it. There is some biological variability, but in reality, it's these reference intervals the problem. And we're also not using a marker enough called FSH. Have you ever heard of that one? So FSH is a marker that our brain releases that says, is there enough hormone around? Do I think there's enough hormone around? So this is the way that it can be extremely personalized, is that if your FSH is elevated, but your hormones are normal, but your FSH is elevated, this is a sign that your brain is trying to stimulate the ovary to make more hormone. This is virtually never ordered.
Yeah. No, it's not. We have to always tell our clients what to actually ask their doctors to order.
Yes.
And then they go into their office, and oftentimes they have to really advocate for themselves, because they're like, oh, you don't need that. But oftentimes because they don't even know what it is and they don't know how to interpret it.
Interpret it. And then the labs aren't interpreting for them, and they don't know, there's no reference interval. So what do I do with this FSH or even the LH, or like for PCOS, when LH is really elevated, doctors are like, because there's literally no training on it. So, this is a really, so the labs are, it's not that there's any problem with the lab. It's the interpretation, what to order, the reference intervals is not been really standardized or established.
Wow.
In the way that it needs to be, so that everybody's doing the same thing, like we've done for men. We are a decade behind men. Men's hormone replacement therapy, they've done this. They've looked at what is the optimal dose to get the optimal reference range based on FSH or LH. So
even what you were saying earlier about how there's a lot of doctors who will prescribe testosterone to women, it makes sense now that you explained it in that way. And I often see that myself, and I'm like, I feel like every woman needs progesterone. I don't understand why that's not the first thing that everybody prescribes. Like, to me, it's such a no-brainer.
a lot of women come on those injections and pellets, and they have to wait for the pellet to wear off, and they feel terrible for the whole time. No, I mean, when we talk about a woman, like everything is regulated by progesterone, even her immune system, So I mean, her immune system can be totally disrupted on testosterone therapy alone. Autoimmunity is caused by low progesterone. So even protecting, and if we want to prevent aging and disease, the immune system is core for doing that. We have to keep the immune system strong and healthy, and progesterone's needed for that too. So even literally everything,
Yeah. everything. And I love that you treat women younger because when I look back on just my whole story, and I started taking bioidentical, like prescription hormones, because I was dabbling on with over-the-counter stuff because I was desperate. Like I was just like, I need hormones. I know what they do to the body. I knew the power of them because I have been teaching women for years. But when I started, it was really in my mid 30s that I started to notice these symptoms. And I didn't really start until I was, I think, 39 or 40 on prescription. And I'm like, gosh, I could have started earlier and I would have felt much better.
And you suffered or tried to find all these for so long and try supplements and try the
Yeah.
things.
Yeah.
The disease is about prevention. Like it's
Mhm.
harder to treat heart disease. It's easier to prevent it. And heart disease at age 40 actually started in your 20s, and
Yeah.
we know that I think if you've talked to women, they start problems at age 30. It's not 40, 50, or when we're talking about menopause or when the period stops. I actually think hormones drop off by about 80% when we turn 30.
Wow.
We have enough to get pregnant still, right? So we're still seeing fertility in the 30s, but reality is that we're not making anything close to what we were or what we need to be in order, even our stressful lives and all the things that
Mhm.
there's demands that are put on us, we're not making enough hormones to support that in our 30s.
No, we're not. And I see it with clients. I mean, we have women, a lot of women who come to us in their 30s. And when they hear me talking about perimenopause, they're like, am I too young? And I'm like, no, you're not. Just because your doctor said you're not, it's not true. And sometimes I think people think I'm nuts, but it's like, no. And I get it because I lived it. So I have compassion for them and everything you said, stress, the toxins, and of course, hormonal birth control. I mean, I don't think I know any woman who has not been on hormonal birth control at some point in their life.
Yeah. No, it's devastating actually. What we've turned the script and made, demonized our own hormones, and then women are there's still confusion as to the difference, or they think birth control is hormones.
Yeah.
When they start hormone replacement therapy with us, a lot of question I get is, am I going to have the experience I did not tolerate birth control? Is this going to be like that? I'm afraid. And then they don't, if anything, if women could understand that it's hormonal birth control, it takes away your hormones, and this would be important. And then normalizing, I love that you're normalizing it. Yes, perimenopause it's almost the word we should maybe even not use the word. We should just say, you're just not making the hormones that you are. It doesn't matter that you're 24 or 28 or just your ovaries are not functioning and
Mhm.
whatever the reason is.
Yeah, and to your point, I think women hear the phrase menopause tied to that, and they're like, "There's no way I'm in menopause." It's like you're not in menopause, but your hormones are declining. Make no mistake.
We don't
um,
we don't tell men that they're an andropause. We've
right.
overcomplicated it for women. It's not
Yeah.
doesn't need.
Yeah. There's something else I saw because I was binging all your videos, of course, your website. 'Cause I was like, these are so great. And I love how they're short and they're just like really good tidbits of information. So again, ladies, please go to her website and, just binge like I did. But there was one in particular that you were talking about cycling hormones versus taking them continuously. And I mean, it sounded like you like continuous hormone therapy. I do, but I'd like to hear you speak on that.
Yeah, I think there's two things here. One, I think it's important to take a break from the hormones every month because you're preventing receptor desensitization. So since they're hormone receptors, you want to kind of get the hormones off for a brief period of time, and then they work better when you start them again. So 2 to 3 days a month is enough of a break, though,
Yeah.
for those receptors to have a break. And then that's a difference between, and then true cycling, where you're only taking progesterone 2 weeks of the month and part of the month. Women are not making why only take progesterone 2 weeks of the month when you need it every day? You're really not making any, so you're really deficient the entire month, and you deserve to feel great the entire month. And I'm not sure that the research that I've seen is strong enough to support 2 weeks out of the month. The research is
Mhm.
stronger. I'm so glad you agree with me because this is like a lot of people disagree with this, but
Yeah.
research is so much stronger to support keeping those levels high to support you the entire month with
Yeah.
the break. I still think like you want to prevent this desensitization on on the actual receptor, but cycling, I don't see there's any reason to do that. They need the hormone and all the time. In fact, sometimes they can't even tolerate stopping them for 2 or 3 days a month. They need to continuously take them even through that, even for a while to correct some of the dysfunction that's been going on so that they can get rid of their symptoms, the severe symptoms that they're feeling.
you hear people, especially in the online space, they get on their soapbox about cycling and doing things a certain way. And I also have not really seen enough research to back that up. And have really just seen it mostly personally that I don't feel good when I'm not on progesterone all month or on my estrogen. Like, there's no way I would ever stop my estrogen.
Part of it too is when we cycle in our normal, like if we're normal, have a normal ovulating female that's cycling, like for example, when she peaks at ovulation, her estrogen levels get up to potentially like 500 picograms per milliliter or even 1500, 1800 that some studies show. So even this 400 cutoff that we have is ridiculous too. But like, it's a wide range for women. It can be up, it can be down to 200 too, but still there's enough of it around that when it drops again, it's still protective of her. So, and then progesterone peaks up to 25,000 grams per milliliter. So it gets really high. So even if it does get a little bit low at the first part of the cycle, she's had enough of it around. It's in the tissues. It's being stored in the tissue. It's on the receptors for even that week that she doesn't have it. So, but if you're treating somebody with oral progesterone, for example, that 200 milligrams is only 20 milligrams, right? The liver gets rid of 80% of it. So she doesn't have enough of it around to be stored in the tissues and everywhere so that she can tolerate being off of it for 2 weeks. Do you know what I mean? Like really deficient for 2 weeks. You have not prepared her for that drop off. Like, so it doesn't even really mimic a natural cycle anyway. So what are we doing here, people?
Like years ago when I first started learning about hormones, I remember people saying, "Oh, you don't make progesterone all month. You only make it when you ovulate." And it's like, actually, it's not entirely true. We do make it all month. Yeah.
Yeah, exactly. And you have a ton of it around and it's being stored. And so it's being stored in the saliva and the brain and the uterus and like all over these tissues. So it's not even in the serum that you can measure. So how do we know that, we used really, really outdated radioactive immunoassays at the time those studies were done as well. And so it's like we're talking archaic studies to show that. So do we even know that we don't make it all month? I question that. And then also, just because we don't measure it in the blood does not mean that it's not there in the body, right? It's being stored in the tissues. But yeah, this not being women do not understand like the labs and the reference intervals, and this is the problem. Yeah.
A lot of women, especially in their perimenopausal years, they're gaining weight. And I believe that they need to be on hormones. So can you speak a little bit about like how estrogen and progesterone affect weight? And you also have mentioned about how estrogen therapy can even enhance like GLP-1s, which a lot of people are on nowadays.
Yeah, this is really important conversation because we see how important the GLP-1 pathway is now. We have the research to support it because we see how well those injectables are working. But yes, and weight gain and weight loss, well, again, it's all about prevention. If women can get on hormone replacement therapy before they gain all the weight, it's obviously better than trying to lose it later, because you're preventing but estrogen has been shown to help reverse leptin, insufficiency or dysregulation in the leptin pathway. So high protein diets will do this, but if you use it in conjunction with estrogen, it really, really works. Estrogen helps suppress appetite. It helps with, and they work together. So I don't want to just, talk about estrogen. It's just that more studies have been done on estrogen than progesterone. But definitely they both work together in a balance. They work opposite of one another, right? So one, they'll suppress appetite. It'll help emotional eating or like uncontrolled eating kind of a thing too, anxiety, because you're also treating that. But it also is needed to regulate metabolism and gut motility. And I also want to mention the digestion gets worse too, right? So we need digestion to be really good in order to lose weight. And women, this is a thing so there's a couple of things here we can talk about. Estrogen stimulates the gallbladder, and without it, you get this really sluggish gallbladder and liver functioning, which is we need to detox, but we also need that to lose weight. And so women will end up with small intestinal bacterial overgrowth, SIBO, or they'll have like bloating and they can't eat, or they get like really bad cramping when they do eat certain foods or an intolerance to foods. And this is also when estrogen drops off and the gallbladder stops dumping bile into the low intestine. So you can't kill that bacteria that's not supposed to be there. So that's one piece. For weight loss, you have to have like all the stars have to align sometimes for weight loss to happen.
I know it's a complicated one. We tell our clients that, and yes, what you eat matters and your exercise matters, but there's more to it, especially the older you get.
So it's like but if we want to get all these pieces to fall in place, you absolutely cannot do it without the hormones. You can exercise and diet all you want to, but if your hormones are low, everything's going to work against you.
Mhm.
So if you combine the hormone replacement therapy with all these other things that you're doing, it's going to work. And then you need your thyroid to function. And in order to get the thyroid to function to lose weight, in order to make thyroid hormone, we need progesterone. Progesterone's needed to make thyroid hormone. It's also needed to absorb iron. We can't absorb iron from the gut without estrogen. We need iron for the thyroid to work. We need the thyroid to work to get a proper stomach acidity. The stomach won't be acidic and you won't digest food to lose. I mean, everything is, I think if anybody took home, you don't have to know the details, but if you took home, everything's connected in the body in order for all that to happen, for you to lose weight. But yes, there are clinical trials going on too about combining estrogen with a GLP-1 and getting a synergistic effect. So it actually works even better. You get more receptors, increases GLP-1 even more, and you will see better results if you are doing an injection with Ozempic or Mounjaro, or, one of the semaglutides or something like that, or even some of the supplements that are raising GLP-1. If you do it together with estrogen therapy, you will get a better result and faster and more sustainable too. And then it also helps if it's not a long-term therapy. So if you want to get off of the GLP-1,
Mhm.
you can sustain your weight loss if you're
Mhm.
on hormone replacement therapy because it's helping correct the GLP-1 deficiency over time slowly. So yeah, definitely. It's the foundation. I always say like, actually, this is what you need. You're not deficient in Ozempic, like you should really be deficient in these hormones. And I
Mhm.
understand sometimes women need it on top of it, right? To really get that because they waited too long. They wait,
Yes.
they haven't had the reason to help for years. So
No, things weren't being addressed. Thyroid wasn't addressed. No progesterone. They were on all the things working against them, like we said. And then, GLP-1s, they sound like, oh, it's like the magic pill, and that's just kind of the way our society works, right? Everything is reactive with health versus on preventative and addressing things before they get to that point. We see it with clients, and we always say to them, listen, we don't judge you if you want to go on a GLP-1, but just know that you need to also support the body in other ways. Like it's not just a quick fix. Like there's going to be things that you need to really be diligent with, like eating ample protein, strength training, and obviously hormone replacement therapy. So I'm glad that you spoke about that because I don't think a lot of people even know that connection. So thank you.
No, thank you. Like, I mean, people, I understand it. They want all without the work. They want the results without the work. But hormone replacement therapy is that. You can get the weight loss and more. And it just takes like 30 seconds a day to put the hormones on. So
Yeah.
really it's the same thing. You get a lot of benefits without a lot of work.
Yes. And a reminder to you ladies who are listening that once you start HRT, please be patient with the process. Like Dr. Sarah said, it can take 3 months, maybe even more for some women to really adjust your dosing. And you want to make sure that you're working with somebody who you can be in contact with to guide you during that process. So, how can women work with you?
Oh, we want to make it as easy as possible for you to be as healthy as possible. So you can sign up online and meet with me right after you sign up. And then also throughout we have a 6-month journey, really. So you want a starting dose and then make adjustments from there. So by 6 months, though, we expect you to be optimized and feeling really well. So it is a 6-month process, but after that, you should be feeling really well, but you can start online, get started today even. We don't need labs to start, as we talked about the labs. If you're having symptoms, of course, we'll look at labs, but if you're having symptoms, you can get started.
Yeah, I love that. I often say symptoms don't lie, but
and
labs can. Labs can be misleading.
and spend all day chasing labs. But if you're still feeling unwell, then who cares what the lab says?
Yeah.
What you're feeling is way more important.
Yeah. Thank you. That's amazing. I hope everybody checks out her website. I'm going to put it in the show notes. It's innerbalance.com. You are seeing women in 28 states, I believe, and women 21 and older. So you don't have to be 35 or 40 in the typical perimenopause bracket. You can be as in your early to mid 20s to work with her, which is amazing. Thank you so much, Dr. Sarah.
Thank you for having me on. Yeah, it was a pleasure.
Okay. Hey, before you go, if you're struggling to navigate the overwhelming world of hormone replacement therapy, feel dismissed by doctors, and can't afford to spend thousands to get help, check out my brand new course, Perimenopause HRT Roadmap. This easy-to-understand, self-guided course is designed to give you clarity, confidence, and knowledge to decide if HRT is right for you. No fancy health jargon that'll leave you confused, no black and white thinking that leaves you feeling alone and without options. With Perimenopause HRT Roadmap, you'll have a much better understanding of HRT, gain confidence to advocate for yourself, and feel your best in perimenopause and beyond. Get all the details in the show notes. The information provided is for educational and informational purposes only. I am not, nor do I act as a doctor or any other medical professional. I am not providing healthcare, medical services, or attempting to diagnose, treat, prevent, or cure any physical, mental, or emotional disease or condition. The information shared is not intended to be a substitute for the professional medical advice provided by your own medical or mental health provider.